How do you treat acute cholecystitis? We've already made the diagnosis. Today we're going to go through fluid resuscitation, pain control, antibiotics. We're going to talk about the choice of laparoscopic cholecystectomy. We're going to talk about percutaneous cholecystostomy tubes, how to manage them. We're going to talk about morbidity and mortality. We're going to do it all today at Citizen Surgeon. Let's go. Welcome back to Citizen Surgeon. My name is Dr. Eric Pearson. I'm a pediatric surgeon and I am passionate about surgical education. I want to get you comfortable on the wards, in the ICU, in the operating room, and of course, I want you to crush those exams. Today, we're talking about acute cholecystitis. If you have not checked out this video right there on the workup of acute cholecystitis, I want you to go and review that video. So important for what we're going to be talking about today. So let's get right into it. We've made that diagnosis of acute cholecystitis, and what do? Well, first, like always, we want to answer that question, why? So why do we want to treat cholecystitis? Well, we want to treat acute cholecystitis so we can avoid things like septic shock, sepsis, acute emphysematous cholecystitis, gangrenous cholecystitis, an abscess, gallbladder perforation. There are a bunch of things that we want to avoid that are going to happen if we let that cycle of cholecystitis get worse and worse and worse for our patient. And so in this video, we're talking about starting treatment. So what have we already done? Well, we've already taken our history, SRN, OPD, SARA, okay? We've already done our physical exam. We've already gotten our labs. We've already had our ultrasound, perhaps a HIDA scan, and we've made the diagnosis. We have acute cholecystitis, all right? So it's worth going through the differential diagnosis, all right? Well, what is the differential diagnosis of acute cholecystitis or right upper quadrant pain, okay? Well, we're gonna be thinking about things like peptic ulcer disease, gastritis or gastroenteritis. Okay, we're going to be thinking about appendicitis, colitis, hepatitis, a liver abscess, even pneumonia or a myocardial infarction. Okay, so all of these things are included in the differential, and it's important for you to narrow that down with your history, your physical exams, any laboratory tests that you need, then of course imaging. All right, but now acute cholecystitis. So how do we start treatment with this? We have our patient, we're in the emergency room, the ER docs called the surgeon, and now we need to initiate treatment. Well, first, we want to get peripheral IV access, and we want to start fluid resuscitation. We're going to review our labs, and we're going to correct any electrolyte anomalies, okay? So if that patient's hyponatremic, or they're hyperkalemic, or, they have prerenal azotemia, okay? They have a scrunched BUN and creatinine ratio because they're dehydrated and because they're septic and developing that sepsis. So we want to correct electrolyte abnormalities. We want to fluid resuscitate that patient. If it's a child, you want to start with 20 to 40 per kilo of fluid. If it's an adult, we want to start going with maybe a half a liter or a liter, depending on their comorbidities, and then see how those vital signs are responding. Okay, so fluid resuscitation, IV access, and then I'm going to show you here in this nice kind of this flow diagram, all right? Then we're going to go to pain control. Now, pain control in acute cholecystitis does have a few little subtleties that are really important, okay? So the first is NSAIDs work beautifully, okay? So we're making our patient NPO, ketorolac, Toradol, okay? That works wonderful, and kids will dose that at a half a milligram per kilo, up to 30 milligrams as a maximum dose. But I've found that a dose of just 15 milligrams, if we're already maxed out, is enough to get really good pain control, and the literature does support that as well, okay? Now, what are the contraindications of Toradol? If we have a patient with a single kidney, or if we have a patient with renal disease, we want to avoid Toradol because that's going to put a lot of stress on that kidney system, okay? So think about that, but Toradol and NSAIDs are really great pain relief in acute cholecystitis. If we can't use that, or if that's not enough, we can use Tylenol. If they're NPO, you can give rectal Tylenol. Okay, we can also give IV Tylenol. And then if that's not enough, we can start getting into opioids. But with opioids, there's one thing that we have to keep in mind, and that is all opioids are going to cause some constriction of that sphincter of Oddi, okay? So it used to be that we just thought that morphine caused increased constriction of that sphincter of Oddi. That's going to increase the pressure in not only our common bile duct, but our pancreatic duct, okay? And you can see the sphincter of Oddi right here, all right? So any of the opioids though, even if it's Dilaudid, meperidine, those are going to increase that tone and can worsen our symptoms, okay? So just think about that as you're controlling the pain in your patient. Now, as you know, I love to get to the who in surgery, okay? So we said sphincter of Oddi. Well, who was Oddi? All right, well, check this guy out. So Ruggero Oddi, he was an Italian physiologist, okay, 1800s to early 1900s. And what I thought was the cool thing about his story is that he described those muscular fibers and that sphincter at the end of the common bile duct and the pancreatic duct when he was a student, okay? And he wrote about it. And so we use that eponym today, okay? So for the students out there, know that you can make big changes when you're a student. So pay attention, write, publish, do what you need to do, okay? So that's kind of a little bit of a divergence from our talk today, but important to look at the history of surgery, and I love history, so important to have a passion for that too. So let's get into acute cholecystitis. The next thing that's really important to talk about is antibiotics. So acute cholecystitis is inflammation and infection, okay? Often we're gonna see these patients, they're febrile, they're bacteremic, okay? Maybe they're septic. They have an increased white cell count, an increased CRP. You know, that ultrasound showed thickening the gallbladder wall, pericholecystic fluid, perhaps even an associated abscess, or hopefully not, but or gangrenous gallbladder, emphysematous gallbladder, or gallbladder perforation, okay? We're going to talk about those things in a few minutes. So all of these patients need antibiotics. The question is, what antibiotic do you choose, okay? And so I'm going to present this table, so check this table out. And so when you look at this, this is the Tokyo Guidelines 2018. This is updated from the 2013 guidelines. And this looks at mild, moderate, or severe cholecystitis. And this helps us with our antibiotic choice. So a mild patient would be a healthy patient, no organ system failure, who has acute cholecystitis. Okay, that would be probably 85–90% of the patients that we're going to see. Well, what's moderate? Moderate, you can see here, so they have an elevated white cell count, greater than 18,000, all right? They might have a palpable tender mass in the right upper quadrant. The duration of symptoms is longer than 72 hours, longer than 3 days, and they may have marked inflammation, so gangrenous, emphysematous, abscess, any of those things make this moderate severity. And then what is severe? Severe is if you have acute cholecystitis with organ dysfunction. So are we in cardiac failure? Are you in renal failure? Are we in hepatic failure? So do we have a child's class C cirrhotic? Okay, that's going to be somebody with severe cholecystitis. Okay, now how does that help us with our antibiotic choice? So it helps us, and we can see it in this table right here. And I'll put the references to where I got this, okay? So we can look at the penicillins. We can look at the cephalosporins. We can look at the carbapenems, the monobactams, and the fluoroquinolones, okay? And based on if that patient has mild, moderate, or severe disease, we can choose what antibiotic. So if we're going to use a penicillin and that patient has moderate or severe disease, you know, Zosyn or piperacillin tazobactam, all right? If we want to use a fluoroquinolone in that patient, we might use ciprofloxacin with Flagyl, okay? So you can look at this table and this will help you choose the antibiotic. We really want that started within an hour of the diagnosis, all right? And that would go along with the whole surviving sepsis guidelines. We want our antibiotic started as soon as possible. Now, the other question we want to ask ourselves is, after we choose the antibiotic, how long do we need to have that antibiotic going? All right, so in uncomplicated cholecystitis, we can discontinue that antibiotic within 24 hours after surgery or after a laparoscopic cholecystectomy. In more complicated cases, so associated abscess, gangrenous gallbladder, perhaps emphysematous gallbladder, we may choose to lengthen that therapy. But in general, for the vast majority of patients, we can discontinue antibiotics within 24 hours following removal of the gallbladder. Okay, so we have fluid resuscitated our patient. We have controlled their pain. We've started antibiotics, and now we have to do something. We are surgeons, right? So what operation are we going to do? There are some choices. We may do a removal of the gallbladder, so a laparoscopic or an open cholecystectomy, or we may do a percutaneous cholecystostomy too. Okay, so let's talk about each of those. Well, if we've decided that this is a patient that we're going to get that gallbladder out, and I'm going to tell you why we may make that decision, we may have a choice here. So we do have a choice depending on what instrumentation and expertise we have available. And that choice in the modern era is a laparoscopic or an open cholecystectomy. All right. Well, laparoscopic cholecystectomy, as you can see here, 4 small incisions, all about the size of my pinky. Okay. As opposed to a longer incision, okay, a subcostal incision to remove the gallbladder in an open cholecystectomy. That leads to less pain, less morbidity, less wound problems, a shorter hospital stay, increased quality of life, all of these things. So in the modern era, if we have the expertise, the instrumentation, the laparoscopic or robotic cholecystectomy is the choice. And I'm going to do another video where I talk about how I do a laparoscopic cholecystectomy, take you through the different steps and the different ways I think about a patient that may have a difficult gallbladder. Okay, so stay tuned for that one. But in reference to a difficult gallbladder, it's important that any surgeon that is removing a gallbladder for acute cholecystitis has to have a few techniques in their bag, a few tricks in their bag. So they got to know the subtotal cholecystectomy approach, okay? A top-down cholecystectomy approach. I've used that a number of times when that inflammation is really severe down near Calo's triangle. We talked about all that anatomy in that gallbladder video, so definitely check that out, okay? And then third, it's important to know when you need to convert to an open cholecystectomy because we don't want to risk injury to the common bile duct or bleeding from the hepatic artery or the cystic artery or the liver. That can be quite severe. Okay, so subtotal cholecystectomy, top-down approach, and of course, when to convert. And we'll talk about all of that in the cholecystectomy video that's going to be coming up. Now the question becomes, who gets a laparoscopic cholecystectomy? Well, laparoscopic cholecystectomy should be the procedure of choice in all patients except those who are extremely critical ill, have severe anesthetic risk. All right, and we're going to talk about what our choice might be in those patients. But all others, laparoscopic cholecystectomy is the choice of therapy. And I should mention, when I say laparoscopic cholecystectomy, I mean surgical removal of the gallbladder. So they might be laparoscopic cholecystectomy, that might be a robotic cholecystectomy. So what I really want to drive home is surgical removal of the gallbladder. So a lap chole or a robotic cholecystectomy, or however you choose as the surgeon to do that. Now that we know what therapy we're going to offer, the question is, when does the gallbladder come out? All right. So the gallbladder, laparoscopic cholecystectomy, or robotic cholecystectomy, the gallbladder needs to be out within 72 hours. Okay, if it's out within 72 hours, then we're not going to put our patient at increased risk of morbidity. Okay, so early cholecystectomy is associated with improved outcomes. There is a lower risk of surgical site infection. There is a lower risk of bile duct injury. In fact, the risk of bile duct injury increases every day. Okay, and so I'm going to put a link to that paper in the description below, so check that out. There is a decreased length of stay in the hospital. There is lower rates of conversion to open if you operate early. Okay, there is a shorter duration of surgery and an improved quality of life. So these are all reasons why we want to get that gallbladder out before 72 hours. And of course, the earlier we take it out, the better for all of these reasons. So the question becomes now, what if we can't take it out within 3 days? All right, how long can we wait? Well, literature tells us that we should be removing the gallbladder within 7 days of diagnosis or within 10 days of symptoms. If it's been longer than that, then we may need to give antibiotics, decrease that inflammation and infection, and do an interval cholecystectomy, much like an interval appendectomy, at 6 to 8 weeks once that inflammation and infection has been resolved. Now ask yourself, are there any indications for no matter what the surgical risk or the anesthetic risk, we need to get this gallbladder out? All right, so that is what we might describe, or what we do describe, as an emergency cholecystectomy. So we do the emergency cholecystectomy in a gangrenous gallbladder, in an emphysematous gallbladder. We're going to see air in that gallbladder wall, or in a patient that has gallbladder perforation. Any of these three, that patient needs that gallbladder out, regardless of the surgical risk. Now, that means you may need to optimize that patient, fluid resuscitate, start antibiotics, treat that septic shock, but that patient's going to need their gallbladder removed. Now, another question that's really important, how about an associated stone? Okay, now we talked about this in the cholecystitis video, so if you haven't checked that out, make sure to watch that video. We talked all about how to diagnose these associated stones. Now, there are a number of treatment options that we have to manage that patient that has acute cholecystitis with an associated stone, and it's important to remember that this can be up to 15% of patients. So you really need to be comfortable with not only taking the gallbladder out, but answering this question, how am I going to manage an associated stone? So what are the options? So the first option, after we've made that diagnosis, we're concerned about an associated stone, is laparoscopic cholecystectomy with an intraoperative cholangiogram and laparoscopic common bile duct exploration. Now, I'll talk about this in the laparoscopic cholecystectomy video, but this is option number one, and this is what I prefer to do as a surgeon. And there's good literature to support this. So you can check out this meta-analysis looked at 11 different trials comparing laparoscopic cholecystectomy with IOC, intraoperative cholangiogram, and common duct exploration versus ERCP preoperatively followed by lap chole. And they found that the surgeons who performed a lap chole with IOC and duct exploration had superior technical outcomes as well as a decreased length of stay. All right, so check this paper out. There'll be a link in the description below, but it's really important to have that technical skill set if you're going to be doing laparoscopic cholecystectomy. Now, what are the other options? Well, we could do a laparoscopic cholecystectomy with an intraoperative cholangiogram followed by an ERCP. So perhaps we're not sure if they have that associated duct, okay, maybe a moderate risk of it, okay? And so, but we do the IOC, we find that there's a stone, well, afterwards, we can have that patient get an ERCP, right? Option three, we can do a preoperative ERCP followed by a laparoscopic cholecystectomy. Okay, that's performed in a number of institutions, and that's a very common approach. And then fourth, kind of a rendezvous laparoscopic cholecystectomy with endoscopy or an ERCP intraoperatively. Okay, so that's an option if you do have that instrumentation and expertise at your hospital. So now a really important question, okay? What if that patient is severely ill, okay, critically ill, has high anesthetic risk? Maybe this is a 70-year-old patient with acute cholecystitis and heart failure. They're on pressors in the ICU. What are our treatment options? Okay, so I want to take a quick break. If you are finding value, if you're liking the content, you like this video, definitely give it a like, give it a share, subscribe to the channel, leave a comment, tell me what you found most valuable or most helpful so far, okay? Love to engage with you guys, so if you leave a comment, I will get right back to you. Okay, so let's get on to it. We got this critically ill 70-year-old male, heart failure in the ICU. What do we do? Well, antibiotics and drainage. As long as we've ruled out the need for an emergency cholecystectomy, okay, we got to think about antibiotics and drainage, okay? So antibiotics, this patient most likely is going to fit that severe category of those Tokyo guidelines, okay? So because he has acute organ dysfunction, acute organ failure. So if we're gonna choose a penicillin, we're gonna start right with piperacillin tazobactam. If we're gonna use a carbapenem, maybe we want meropenem, okay? So you're gonna choose based on the antibiotic of your hospital and your local practices, but this patient certainly is severe when it comes to the Tokyo guidelines, and so we want to initiate a very strong, effective antibiotic. All right, second is drainage. Now, what does drainage do? Well, drainage removes the pus and the inflammatory debris. So what does drainage do? Well, drainage removes the source of sepsis. So it drains the pus. It drains the inflammatory tissue, inflammatory fluid that's causing sepsis and septic shock so that we can do a gallbladder removal further down the line. Okay, so what are our drainage options? Well, we can do a percutaneous transhepatic cholecystostomy tube. Okay, that's probably the most common option. It has a very high technical success rate. Okay, well, we could also do endoscopic transmural drainage, so through the intestine or the stomach wall to drain the gallbladder, or we can do endoscopic transpapillary drainage of the gallbladder. Okay, so these are three options to drain the gallbladder, but in my institution and the physicians that I work with, percutaneous transhepatic cholecystostomy tube is the choice that we use, and I think that it has very good success when it comes to these critically ill patients. But remember, we only want to do this in patients that are critically ill or have anesthetic risk and cannot undergo surgery. Has this question been asked? Yes, it has, and we look at this trial right here. So the chocolate trial compared cholecystectomy versus cholecystostomy tube. And it's important to know that in cholecystostomy tubes, there is a very high complication rate, okay? So you can have tube dislodgement. The tube can get clogged and it won't drain effectively. You can have bleeding from the tube, okay? So this happens in up to 65% of patients. So those complications are quite common compared to complications in that cholecystectomy group. So the chocolate trial, I'll put a link in the description below. Definitely read this, check this out, educate yourself. Okay, so once we got the tube in place, okay, we got this cholecystostomy tube in place, what are our options? Okay, well, number one is we can keep that tube until our interval cholecystectomy in 6 to 8 weeks. We're going to talk about all that timing here in just a couple of minutes. We can cap the tube, okay? So we cap the tube until we use it. And we're going to talk about when you might want to do that, okay? Or we can leave this tube in situ, and perhaps if the patient continues not to be a surgical candidate, we could do a removal of the tube or lithotripsy through the tube. There's some options there, okay? So 3 choices: keep the tube draining, cap the tube, perhaps remove the tube, okay? Or keep that tube in for the long term, or perform lithotripsy for the tube to break those stones up. Okay, now I want to check out a really interesting paper that gives us a nice clinical pathway after we've put this percutaneous cholecystostomy tube in. So check this out. So this paper right here, so read this one, it's freely available. I'll put a link in the description, but this is about managing cholecystostomy tubes, okay? So let's go to this flow diagram. All right, so we have acute cholecystitis. They weren't a surgical candidate. They got a cholecystostomy tube. Okay, well, the first thing is we do a clamping trial. So we cap the tube, and we do that right around 3 to 4 weeks. So at 3 to 4 weeks, that fistula tract where we place the tube is going to be well formed. So if we pull that too early, then we can have bile spillage into the peritoneal cavity. We can have biliary peritonitis. We don't want that. So we wait at least 3 to 4 weeks when we're considering tube removal. Okay, so at this time, we clamp the tube, we cap it, and we see, well, does the patient tolerate it over 24 to 48 hours? Do they tolerate having that tube capped, or do they become symptomatic? All right, well, in those patients that become symptomatic, we're going to want to do a cholangiogram through that tube. And if we see that on that cholangiogram, they have stones in the common bile duct, well, we can have that patient get an ERCP and remove those stones from the common bile duct, okay? Some surgeons may choose to do a lap chole with IOC and a laparoscopic common bile duct exploration, but in this paper, they chose for those patients to get an ERCP to remove those stones for subsequent surgery. Okay, now if we do the cholangiogram and we see, well, the cystic duct has a stone that's obstructing, then we know that we have to keep the tube in place, keep the tube draining because the gallbladder can't drain, and then set that patient up for a subsequent laparoscopic or robotic cholecystectomy, or perhaps the patient that can undergo surgery, perhaps they need lithotripsy or some other options. Now, if we go a little further down the pathway, if the patient that had the common duct stone gets a ERCP, then we can do another clamping trial. If that's successful, we can remove the tube. That patient can have subsequent operation, or if that's not successful, we could keep that tube in place and perform that laparoscopic cholecystectomy, usually at around 6 to 8 weeks. Okay, now let's go back up. So let's say that we did our clamping trial after 3 to 4 weeks and it was successful. Well, in that patient, we can remove the tube, okay, and then perform that laparoscopic cholecystectomy at 6 to 8 weeks after that inflammation has resolved. So this is a nice clinical pathway. Okay, you decide and educate yourself how you want to manage it, but I think that this is a nice reference, so definitely check this out, read this. So lastly, I just want to talk about surgical risk. So what is surgical risk when it comes to cholecystectomy in patients with acute cholecystitis? Well, the overall mortality for this operation is right at 3%. And that mortality is increased in patients that are elderly as well as patients with diabetes. Now, when we talk about, well, what is the conversion rate, the need to go from laparoscopic to open cholecystectomy? Well, that published rate is 10 to 20% in acute cholecystitis, and that is increased from just at 5% or less in gallbladder removal or cholecystectomy without acute cholecystitis. So something to keep in mind there. Now, what are the risk factors for conversion? Well, you're at an increased risk of converting to an open cholecystectomy in patients that have severe adhesive disease in the abdomen, patients that have had previous operations in the abdomen. The elderly and, of course, males have an increased risk of converting from laparoscopic to open. We don't know exactly why that is, but that's what comes up when we look at these epidemiological data or the statistics. Now, one thing I think we should all be using when it comes to estimating surgical risk in our patients is the ACS NSQIP risk calculator. So check this out at the American College of Surgeons website. It's educational. It's also very helpful when we're counseling our patients because it takes all their comorbidities, their age, gender, everything into consideration and can estimate what our surgical risk is, not only the mortality, but all of the different morbidities, okay? So really great resource. Check that out at the American College of Surgeons. I'll put a link in the description. Okay, today, acute cholecystitis, the treatment. We did the workup previously. Today we did the treatment. We talked all about resuscitation, pain management, antibiotics, looked at those Tokyo guidelines. Then we went into a deep discussion on surgical treatment, drainage. We even talked a lot about the literature, talked about the chocolate trial, and then how to manage that percutaneous cholecystostomy tube. So I hope you liked that today. I think this was really high value content because we see inflamed gallbladders and cholecystitis a lot as general surgeons. So if you liked it, give it a like, give it a share, subscribe to the channel, turn on notifications so you know when these videos are coming out. I'm trying to get them out every week. And as always, study hard, stay safe. I'll see you next time.